Right, good morning everyone, and welcome to session 4 of our RaCEEs course. Today we're going to talk about outcomes, and I'm co-running this session with Misael from MIDAS team and from Lancaster University. As usual, I need to say this, the session will be recorded and made available on the ARC No West Coast YouTube channel. If you have any questions about the recording, do let us know. So, before we start, Maria and Taylor, did you have time to do the homework, or did you have time to look at the homework from the previous session, or do you have any questions for us in general from the homework or from the course, more generally?
I didn't have time. I was out on training all week last week, so I just haven't had time to catch up. But I'm slowly catching up with the ones I've missed as well. Sorry
That's
about
fine.
that.
That's
Same
fine. Don't
here.
worry.
Sorry, apologies.
No, don't need to say sorry. Don't worry.
It's been a really busy week here, so really
No, that's
apologies.
fine. So whenever you have time to do it, or if you look at the slides, you got any questions, just feel free to contact us. We are here to help you. Okay, even if you ask us like in a few weeks' time, can you got a question about the costs? That's fine. It doesn't really matter. We are really more than happy to help you with things. So in terms of where we are with the course, and this is session 4 about the outcomes. So we're still within the methods of an economic evaluation. We talked about cost last time, and now we are going to cover the outcome data. And this is where we are fitting in terms of the commentary, which we are going to co-produce at the end of the course. So we are basically within the method section of the commentary, and the homework, which I will give you later on, and that you will do in the next couple of weeks, will be all about outcome data, and we will use that information that you're going to extract from the paper in order to write up the method section of the commentary. Right, overview of today's session. So the aim is to identify and describe the characteristics of the outcome data and the type of discounting used in economic evaluation. So I will introduce this session by talking about the cost effectiveness plane, and then Misael has got a very interesting part around cost effectiveness decisions. Then we will talk about clinical effectiveness outcomes, and then composite outcomes, more specifically QALYs, quality adjusted life years, which I'm sure you will have heard of before. And then there's a smaller part around discounting. Okay, so in terms of what we are going to consider today, you will remember last time we covered the costs, and this time we're going to talk about the consequences of the outcomes of the different alternatives we are comparing in an economic evaluation. So your own specific economic evaluation paper will talk about alternatives, might be 2 alternatives, 3 alternatives, 4, and so on, and there will be costs and consequences associated with those alternatives. So today we are going to focus on the consequences or outcomes of the alternatives. Okay, this is the cost effectiveness plane. I'm not sure if you've seen it before, but we're going to talk through this plane step by step. So it's a typical plane with a vertical and horizontal axis. On the vertical axis, you can see cost. So the more we go to the northern side, let's say, of the plane, the new treatment will be more costly. The more we go to the south, instead, the new treatment will be less costly. So it's just a depiction of how costly is the new treatment compared with the alternative. Similarly, if you look at the horizontal axis, the more we go to the east, the new treatment will be more effective. So it will be more beneficial in terms of some clinical or health outcomes. And the more we go to the west, then the new treatment will be less effective. So vertical axes are cost, and horizontal axes are the horizontal axis is representing the effectiveness of the new treatment compared to the alternative, which might be standard of care, for example. Now you got these 2 axes. So these 2 axes are dividing the plane in 4 quadrants, and you can see the 4 quadrants there: northwest, northeast, southeast, and southwest. And each quadrant represents something in terms of interpretation of what's going on in the comparison between the new treatment and the existing treatment. So let's have a look at the northwest quadrant first. you got a quadrant where the new treatment is more costly, but at the same time is less effective. So it's going to be more expensive to implement a new treatment, and you're not going to get the same health outcomes as you do with the existing treatment. That means the decision here is quite easy, because the existing treatment will dominate new treatment. So the existing treatment is going to be cheaper and more effective. So it's a quite straightforward decision here we can make. Moving to the southeast quadrant instead, we got the opposite scenario, where the new treatment is more effective and is less costly. So in this case, the new treatment will dominate the existing treatment. Now we're going to move to the other two quadrants, where the interpretation will be a bit trickier. So let's start with the southwest quadrant. The new treatment here is less costly, but is also less effective. So it's cheaper to implement a new treatment, but at the same time, you don't get the same health outcomes as you would with the existing treatment. So what do you do here? Again, it's a tricky decision. There might be ethical concerns involved with this decision. So it's not a straightforward decision, and it will depend case by case. When I talk about ethical concerns, it's because, of course, you will have to forego some health outcomes in order to implement a new treatment, and that can meet some opposition from like society or the political arena. The most common quadrant, I have to say, is this one, the northeast one, where the new treatment is more costly and at the same time is more effective. So typically when you implement something new, there will be additional costs which we need to consider. Cost to train a healthcare or social care professional, cost to buy some equipment in order to incorporate the new treatment into clinical practice. For example, cost of adopting a new surgery, equipment, and so on. So the new treatment will result in more costs. At the same time, if we are considering a new treatment, it's probably because there is some promise of additional effectiveness compared with the standard of care. So the new treatment will bring about more health outcomes and more gains from that perspective. And again, the decision is not straightforward here. We have to think about pros and cons, and we have to think about the value for money. So what's the price we are willing to pay in order to get more effectiveness? And that's something we will cover a bit more in depth in session 5. So we need to think about this threshold we have in mind in order to understand whether we could implement the new treatment. And when I talk about threshold, is exactly this: the willingness to pay. We have to get an additional unit of health outcome. Any questions so far? Okay. So this is just to introduce you to some concept around how costs and outcomes might interact together. And I'm going to stop sharing my slide now, and I'm going to leave the next part to Misael.
Can you see my screen now?
Yeah.
Okay, great. Now we will see an example of the cost effectiveness decision. Let's suppose that there are 2 new cancer drugs available in the market that can be paid by the NHS. So let's assume that drug A can extend life by 1 year, and it costs £100, and drug B costs, or extend the life also by 1 year and cost £300. So this round number is just an example. So neither drug costs £100. So we can say £10,000 against £30,000, or £100,000 against £300,000. So it's just a number, the numeric example. So for simplicity. So here, drug B extend life by 1 year and cost 3 times. Which one to choose? I think we can choose, we can safely say that we are choosing drug A. And this is because there is no reason of choosing drug B. We will waste money. We will waste £200,000 financing drug B. This is a straightforward example. But actually, what happens in reality is what we are not comparing two drugs that has the same power in extending life with the same cost. Usually we find this example in the north east quadrant. So north east quadrant, if you remember, one drug costs more, but also extend life by more years. Here, it's not straightforward which one to choose. So we need a concept which is called net benefit. The net benefit is the number of additional years of life compared with the overall NHS. We need a reference point. This is called an opportunity cost. So again, we need an overall comparator. Let's assume that the NHS is producing 1 additional year of life in the overall system with £50. So which means if we like to finance a new drug, we'll need to use these existing results, these existing resources. And this will be the resources that we will forego in order to have one of these drugs. This is called an opportunity cost. And the opportunity cost and the net benefit is estimated like this. So drug A costs £100 and drug A can extend life by 1 year. However, with the same £100, the NHS can produce 2 years because each year is produced with £50. Okay, so at the price of 100, drug A can extend 1 year of life. With the same £100, the NHS can produce 2 years of life. So the NHS will lose elsewhere 2 years of life to finance drug A, which will produce 1 year of life only. So we do the subtraction, and the net benefit is minus 1 year of life. Okay. What will happen with drug B? Drug B cost £300 and produce 2 years of life. But the overall NHS system is producing 1 year of life at a cost of 50, which means with these £300, the NHS can produce 6 years of life, 300 between 50. So, which means that here we are reducing 6 years of life in the NHS in order to only gain 2 years of life with drug B, which means minus 4 years of life. So this is the estimation below. So at the price of 300, which is the price of the drug B can extend 2 years of life. With the same £300, the NHS, remember the NHS is producing 1 year of life at £50. With the same 300, the NHS can produce 6 years of life. So the math is simple. The overall system is reducing 6 years of life in order to finance drug B, which is gaining only 2 years of life. So, which means drug B is reducing 4 years of life. Which one to choose? None of them. Okay. So we need, in order to decide which drug to choose, we need a reference point, an opportunity cost. And the opportunity cost is how many years of life I'm losing in order to finance that drug in the current system. And the NHS is producing 1 year of life at £50. Let's say that, another hypothetical example, the opportunity cost, the number of years of life that the NHS is producing, 1 year of life, cost £100. Okay. Now, the opportunity cost is £100 per 1 year of life. This is what the system is producing currently. So for drug A, now we can see that it's the same, isn't it? Drug A is 1 year of life, £100. Drug, the NHS is 1 year of life, £100. So it's the same. So which means here, the policymaker is indifferent between financing this drug or not. We do the same math with drug B. And here, with £300, drug B is producing 2 years of life. But with £300, the NHS could produce 3 years of life, which means financing drug B will reduce 1 year of life. I hope it is clear, because this is supposed to be straightforward. And we can see now that when the threshold, the opportunity cost, reach the value of 100, drug A is indifferent. Okay, financing drug A now is indifferent. So this exercise means that if the NHS can produce 1 year of life at a value of £101, then financing drug A is cost effective. Because, you know, drug A will produce 1 year of life at 100, but the NHS is producing at 101. So the NHS is producing 1 year of life at a higher cost. So that is the reason, if the threshold, the opportunity cost, is higher than 100, then drug A could be cost effective. If we continue with this example, we can show that with a value of 200, both of them will be indifferent, drug A and drug B. Financing drug A and drug B will be indifferent. However, if the overall threshold, the NHS threshold, the opportunity cost is higher than 200, let's say 201, then drug B will be cost effective. So what is the message here? The message is that the drug that we will decide to finance, the rule to which of them we choose depends on the opportunity cost, depends on the threshold, depends on how much does it cost to the NHS to produce 1 year of life. Here, to thresholds lower than £100, the policymaker wouldn't choose any of them, because neither drug A or B will be cost effective. With thresholds higher than 100, drug A is cost effective, but only up to £200. Okay, so from 100 to 200, drug A is cost effective. For threshold higher than 200, drug B is cost effective. So this will depend. So now the question is there, the natural question is this as relative as it is? So Also, this is yours, Valerio. Actually, there are studies that situate the NHS threshold between 20,000 to 30,000 pounds. Okay, so if drugs cost more than this for producing one additional year of life, which will be measured in QALYs, then this drug will not be cost effective because it will be higher than the threshold. So that is the main message of this part. Let me know if it is clear. We can go back to the example if you like, and also you will have these slides so you can review these basic maths.
Thank you, Misael. Any questions? Okay, I'll start sharing my bit again. Okay, so Misael was just talking about some cost effectiveness decision and so how cost and outcomes can interact with each other and how we make decision regarding potentially gaining some years of life at the expense of course, incurring some cost to get those. You will remember this table now from session 2, I think it was, where we talk about the different types of economic evaluations. And in terms of the outcomes, I'm going to focus today on 3 types of economic evaluation. First of all, CCA, the cost consequence analysis, and CEA, the cost effectiveness analysis, where things are measured in natural or monetary units. And then I'll talk also about the cost utility analysis, or CUA, where outcomes are measured in terms of health years. And we will explain that concept a bit more later on, talking about QALYs, quality adjusted life years. So let's start with the CEA, cost effectiveness analysis, and CCA, cost consequences analysis. In this type of economic evaluation, outcomes are typically measured in natural or monetary units. You can see things in monetary units in CCA, so cost consequences analysis, where you have all the outcomes separated and in a disaggregate format, let's say. Instead, for a cost effectiveness analysis, things are focusing around one clinical effectiveness outcome of interest, might be the primary outcome of a clinical trial, for example. But in sum, clinical effectiveness outcomes, they measure how good interventions are. And as was saying before, in a CCA, we'll have a list of different clinical or even process outcomes sometimes. So not only, for example, health outcomes, for example, weight loss, but also process outcomes, satisfaction with a specific treatment in specific case might be important. In a cost effectiveness analysis, instead, people will tend to focus around a primary outcome measure, so specific outcome measures which represent the effectiveness of the intervention. In particular, cost effectiveness analysis aim to calculate the cost per additional gain in health. So we go back to what we were saying before. We got this concept around incorporating cost and outcomes considerations together. And we need to understand what is the cost per additional gain in health we are obtaining from implementing the new intervention. What do we mean with this gain in health? Well, it could be something long-term. For example, cost per life year gained, and that was the example used by Misael before in his slides. Could be improvement in quality of life. Again, could be medium or long-term outcomes here. But sometimes it's not feasible to try to capture these outcomes in the long term. It might take a long time to do that. So you will have studies focusing, for example, surrogate outcomes, which are probably more short-term, like 1-point reduction in blood pressure, 1 kilo weight loss, malignant cancer detected, additional vaccination, avoided hospitalization test. These are all examples of surrogate outcomes that you might see in research articles or economic evaluations more specifically. At the end of the day, the concept remains the same. In cost effectiveness analysis, you will see the metric which will be cost per additional gain in health, so per additional vaccination, for additional kilo weight lost, and so on. In a cost utility analysis, instead, we are going to talk about composite outcomes. So we are trying to combine a couple of elements together. The typical outcome you will see in a cost utility analysis is healthy year, which is measured or estimated by the quality adjusted life years, so QALYs. And in particular with healthy years, we're trying to combine quality of life and life expectancy together, okay? Quality and quantity together. And this concept is practically measured by the quality adjusted life years, or the QALYs. So in a cost utility analysis, you will end up with a cost per additional QALY. So QALY is your health outcome here. In the same way that 1 kilo weight loss was your clinical effectiveness outcome, in a cost effectiveness analysis, here we got a composite outcome instead, which is the QALY. And we are going to focus on the cost per additional QALY in a cost utility analysis. Now, you might ask yourself, what is the benefit of the QALY? Why in health economics and economic evaluations we use the QALY so much? Well, if you think about the examples we were looking at in the previous slide, like reduction in blood pressure, weight loss, they could be relevant, for example, for people with, of course, weight problems, so hypertension, right? But if you take blood pressure, it might not be so relevant for other health areas, okay? Or maybe not so relevant for other health areas. And the same for weight loss. Again, it might be relevant for people with weight problems, but not for other health or disease areas. The QALY instead is going to be having some relevance, at least in a lot of different disease or health areas, because it's really a generic health-related quality of life outcome, which try to combine quality of life and life expectancy. So these concepts are going to be relevant and significant for a lot of health or disease areas. And that's why QALYs are used in economic evaluation, because they tend to be that common currency that you can use to make decisions in diabetes, stroke, cancer, hypertension, and so on. And it's good to have this common metric, because then you will know that an intervention in diabetes will cost X amount of money to get one additional QALY. In a stroke, an intervention will cost X amount of money to get, again, an additional QALY. So you can compare different interventions applied to different health or disease areas. And that is not always possible with, for example, a reduction in blood pressure, okay, or weight loss. That's not, those are really not like common currencies you can use for different health or disease areas. We are not going too much into the theoretical foundations of the QALYs, but I'm going to say that the QALYs are based on preference and utilities that people attach to specific conditions, to specific health states. And if you know a bit about economics, you will know that utility, so the concept of utility, is a very important concept in economics. So, and this concept substantiates the QALYs as well. And if you want to know more about utilities, we have an ongoing series of vlogs on health economics and economics more in general, and I can share the link with you later on. And in one of these vlogs, we also talk about utilities. Before I leave the next part to Misael, I'm going to show you how to extract and write up the information on the outcomes from a paper. So you will know this article by now. So it's the article on advanced Parkinson disease, which we used to prepare our first RaCEE, first ever RaCEE. And in the methodological section, the authors mentioned the outcomes they were going to consider. These are highlighted in green here: life years and quality adjusted life years. And so you can already basically deduce that the authors here were running a cost effectiveness and a cost utility analysis. And in our RaCEE, this is how we summarize this information around the outcomes used by the authors. And this is just a small paragraph from our RaCEE where we try to summarize the information about the outcomes. Any questions so far? Okay, Misael, over to you.
Okay. Okay, now let's dig a bit in what is QALYs. QALYs is a short term to quality adjusted life years. And it's a weighting combination of length of life and health-related quality of life. And this allows, as Valerio said, comparability across diseases, conditions, and areas. So we like QALYs because it's flexible to compare intervention across diseases. For example, we can compare interventions in cancer with, let's say, hip replacement. So we can compare a broad interventions using QALYs. But QALYs is really in the concept, really basic. QALYs is years of life times quality of life. And this quality of life has a value from 0 to 1. 0 is death, and 1 is perfect health. So quality of life is 1. 1 year of life will value 1 QALY. If quality of life is 0.5, so which means 50% less, 1 year of life will value half 6 months of life. Okay. 1 year of life with a quality of life of 50%, it's equivalent to 6 months at full value of quality of life. So this is the way of comparing, not only extending life, but also extending life with quality, which means basically without complication, without suffering. How we estimate QALYs? We estimate by questionnaires, by asking people questions, usually in randomized controlled trials. And then we take weights from general population. So these surveys, this questionnaire, which is applied to each individual for treatments, is compared with weights from a general population, which comes from another survey that comes from the general population. And then we multiply this and we have QALYs. The most common measure of quality of life comes from this questionnaire that is called EQ5D. So, and this has 5 dimensions, measures mobility, self-care, usual activity, pain, discomfort, and anxiety and depressions. And it has 2 versions, with three levels and with 5 levels. So in the version of 3 levels, we have no problems, some or moderate problems, or extreme problems. So we have only 3 levels. And in the 5 levels, we have no problems, slight problems, moderate problems, severe problems, and unable to perform daily activities, for example. And then from these questionnaires, they got a full score, so which is deducted from these problems in each dimension. We will see this by example, with one example. For example, in the EQ5D 3 levels, in mobility, we only have 3 questions. I have no problems in walking about. I have some problems in walking about, and I am confident. I am confined to bed. So, and the patient will only tick one of these. Okay, so 3 levels. Whereas in the version of 5 levels, we have 5 types of questions. I have no problems walking about, which is the same as this one, isn't it? And then I have a slight problems walking about, have moderate problems walking about, I have severe problems walking about, and I am unable to walk about. We have 5 levels. And again, patient will choose one of these. The issue is that as we have 5 dimensions and 3 levels, there is 243 possible health states. So this is the combination. Whereas in the questionnaire with 5 levels, we will have over 3,000 health states. So it depends on, so the 5 questions with 5 levels, we have more information. So we have more granular information because it has 5 levels. Okay. And then we compare this with an information that comes from a survey for the general population. This is the table that we currently use, which was carried on in 2018 with 5 levels. So, and this is how we can read, okay? It's easy, okay? For example, the first line is the constant, which is 1. If everybody else is 0, then this is perfect health. And the rest of the coefficients is what percentage of health it will be reduced by if one person suffers one of these problems. For example, I will do one, Taylor do another, and Maria will do another, okay? Okay, let's read the first line. Let's say I answer, I have slight problems in my mobility. This 0.05a means if I have this health state, I will have 5.8% reduction in my health. Okay, that is what this means. If I tick slight problems in mobility, this will mean 5.8% in reduction in my quality of life. Okay, Taylor, what will means in self-care if somebody ticks slight problems in self-care?
A 5% reduction in self-care.
That's right. That's right. Okay, Maria, what will mean if somebody ticks, let's say, moderate problems in pain and discomfort? This one here.
So there is like the 8% fee reduction still.
Yes, that's
Yeah.
right. That's right. And then it follows that, for example, if somebody ticks extreme pain, that will mean 33.5% reduction in quality of life. Okay, so let's say I live 1 year more, but with extreme pain. That will reduce my quality of life by 33%. Okay, this is what is meant this table. Then we have a questionnaire with 5 categories and 5 levels, and we will tick one of them. Okay, in mobility, we will tick, let's say, a slight. Okay, in self-care, we tick moderate. In usual activity, we tick unable, and so on. Okay, we can tick. And then what we will do is we will add all the reductions, and then we will subtract from the overall well-being. Okay, let's do this by this example. What happens if we choose the state 2 for the first condition, for the first characteristics, 3, 2, 5, 4, 5. Okay, let's see how this works. Okay, if somebody says somebody ticks immobility slight problems, this will mean 5.8% reduction, isn't it? Okay, and then in self-care, it has ticked level 3, moderate problems. Then it's an additional 8% reduction in quality of life. In usual activities, level 2, slight problems, another 5% reduction. Then pain and discomfort, it's severe problems. This is 27% reduction in quality of life. And then in anxiety and depression, it's the highest, extreme problems. This is 29%, nearly 29% in reduction in quality of life. We add all of them, we subtract 1 minus all of that, and this is 24% on quality of life. This is 1/4. Let's say one individual lives 1 year with all these characteristics. With that year only means 1/4 of that. So it's like 3 months in full health. So because we will multiply 0.247 times 1 year, and this is 1/4 of a year. Okay, this is how it works. Quality measures. What will happen is we can apply this questionnaire to a person who has coronary diseases. We can apply this questionnaire to a person who has cancer, and to another several health conditions, and then we can compare all of those treatments. Otherwise, it will be difficult to unify outcomes. This helps to unify health outcomes across several diseases. And hopefully, this is what will happen with no treatment, without treatment, for example. So the time of death is here, death A, and the quality of life is like this. However, with a new treatment, that life is extended to the B. So more time that these people is living, but also with more quality. Why? Because they feel less pain, less discomfort, less problems of walking, less anxiety. And this means it's closer to 1. You can see here, isn't it? It's closer to 1. So the difference between these two areas will be the quality gain from the treatment. And this quality gain, which is the additional gain, will be used to compare across treatments according to the threshold. So if you remember our first example of cancer treatments, isn't it? Drug A and B. We won't use 1 year of life. We will use 1 QALY. So the reference will be how much is costing 1 QALY with treatment A. 1 QALY is produced with what value with treatment B. So the system is producing 1 QALY at what value. So then we will compare the cost effectiveness analysis referring to QALYs produced by treatments compared by the opportunity cost of the NHS, this threshold. Also, how many pounds are spending the NHS in producing 1 QALY. So that will be our currency of comparing drugs. So let's say, please, if I was a bit not clear, I can repeat any part that you like. Okay, Valerio, then over to you.
Thank you, Misael. Okay, I'll share the slides again. Now, I'm going to talk a bit about some criticism of the QALYs. You now seen how the QALYs work in terms of measuring them and trying to estimate their value. And you probably thought maybe there are some problems attached to the QALYs, and I'm going to list some common problems here. But I would like, first of all, to go back a few slides here and think about these weights here. And these are all like utility decrements, if in a way, like reductions in quality of life. And Misael was listing them and talking about them before. Just want to ask you, Maria and Taylor, these weights come from the general population, okay? So there are, as Misael was saying before, there are surveys which are done and administered to the general population, and they ask people, okay, what do you think is the reduction in quality of life with light mobility? What do you think is the reduction in quality of life with moderate self-care? Why do you think they ask this question to general population, not to people with the actual disease or condition?
To have a baseline,
Okay.
like a general population baseline.
Yeah. So okay, yeah, I think that's probably something they consider, yeah, to have maybe some objective, let's say, view on a particular health state, and that's
I think Taylor is
Taylor.
unmuted.
Yeah, okay. Okay, the question. Okay, is there a set time after treatment when impact is measured, or does it vary by drug intervention? Um, okay, if you think about a clinical trial, of course, the Q5D tends to be administered at baseline and then a follow-up whenever that might be, like it could be a few months after baseline, 1 year or so on. And that is then used to estimate outcomes in the long term. And that's what modeling will do then after. So if you have a follow-up of 1 year, you get the Q5D value at 1 year, then you can use modeling techniques to extrapolate that value onto the long term. Yeah. But it will depend on the drug intervention, of course. So when it's reasonable, when it's clinically meaningful to capture the Q5D for some intervention, might be a few months after the beginning of the study. For some others, might be 1 year, for example.
It will depend on the treatment, isn't it? So
Exactly.
some treatments can have an impact in the maybe in immediate term, so and others will have impact in the longer term. For example, I was just thinking in colonoscopies, they are preventing cancer in 5 years or maybe more. So, and they are repeating not every year, for example. So they will change according to treatment.
Yeah, that's it. And of course, with clinical trials, you have to think with as economists work together with other people, of course, in a team, and sometimes health economists will have a say in when to administer the Q5D. Like we would like to, for example, to be captured quite often, but that could cause some burden on the patients, and of course. You'll have to think about the resources from a team point of view in terms of capturing the Q5D quite often, so it's not always possible. And you'll have to go with the, more overall decision around when things are captured, for example, regarding other instruments that are being administered as part of the trial. So what I wanted to underline here with the element around why we are capturing the weight from the general population. Well, typically the reason we do that is because at the end of the day, general population represent the taxpayers, so they will fund the healthcare system. So the rationale for asking people how much they value a certain health state is because, of course, they are contributing to the health system, so they need to have a say in that. Having said that, it's often the case that people will tend to either overstate or underestimate the particular value of a specific health state, and that's one of the criticism of the QALYs. For example, we did some research recently around economic valuation for people with learning disabilities, and people in the general population tend to have quite a catastrophic view of the condition of people with learning disabilities, which actually doesn't reflect what these people live in their everyday life. So you could have some misalignment there between the view of people with the actual condition of disease and the view of the general population. And that's one of the first criticism of the QALYs. Another criticism of the QALY is to do with equity. Misael explained before how we need to combine quality and quantity of life, okay? But what about people who don't have a lot to live anyway? You know, intervention for elderly people in palliative care, they will not gain anyway a lot of life expectancy for intervention. So if you measure QALYs for this type of interventions, then you will probably discriminate against this type of intervention, because QALYs will rely a lot on measuring life expectancy, and that won't be necessarily improving with this type of intervention, for example, end-of-life care. And QALYs will place different values on different people, and also the QALYs you will gain when you are, for example, 20-year-old might be different from the QALYs you gain when you're 50 or 70 years old. So the concept that a QALY is a QALY, regardless of who gains it or loses it, when you gain it, when you lose it, might not apply to real life conditions. Are we also capturing all relevant aspects with the QALYs? Maybe not, because, for example, things like process of care are not really considered. If you administer the EQFID, for example, you don't think a lot about how things are delivered, how interventions are delivered for patients or for people or participants in general. There are, of course, disease-specific outcome measures which are much better in terms of finding and measuring the nuances of the conditions, but they are disease-specific. So it's difficult to then apply this disease-specific outcome measure to another different health or disease area. So we go back to the benefits of using QALYs here. At the same time, we do have nowadays more and more algorithms which allow us to map the scores from a disease-specific outcome measure into the QFID, for example. So we could use this disease-specific outcome measure using their scores, mapping these scores into the QFID scores, and then produce QALYs in this way. There are also alternatives to the QALYs which are available now. One of them is the ICECAP, and it's all about capability of being and doing things rather than measuring health status. So these are interesting developments around what we should capture in terms of people's conditions, so what they actually are at the moment or what they actually are capable of being or doing. And you will see that attributes or dimensions here are quite different to the dimensions we consider with the EQ5D, for example. And then another important point is about externality, so the effects on other people. We talked before about people with learning disabilities, like an intervention will have an effect, in this case also on caregivers, families, okay? And these are not usually captured with the typical way we measure QALYs, which are just directed to measuring the health outcomes of a patient. But there are also ways now we can capture, of course, the QALYs for the caregivers, the families, and so on. And if you're interested about the QALY a bit more, there is a link here to our QALY vlog, which is available on YouTube. And just to conclude this bit, this is a value flower, which is available from the ISPOR, which is the International Society of Pharmacoeconomics and Outcomes Research. A bit of a mouthful that, but it's just to explain here that QALYs and cost represent just two of the multiple elements of values which decision makers should take into account when deciding upon implementing a new intervention. Okay, so we talk a lot about QALYs here, but it's one element which of the different petals we need to take into account. I'm conscious of time, so I'm going to talk very quickly about discounting. So discounting is to do with trying to estimate the value of future costs and outcomes. and there is a recommendation about the discounting factor which people need to apply into future costs and outcomes in economic evaluation. The recommendation comes from NICE, and the discount factor is 3.5%. Discounting is done because there is an understanding, or there is empirical evidence that people will tend to value today things a bit more than tomorrow things. So the future value of things will be lower compared with the present values. You got a formula here, and of course it's there, but I'm not going to go too much into it. But what we need to understand is people will have, let's say, a preference for gaining something today rather than tomorrow. So any future value of cost and outcomes will be a bit less and less and less over time. There are things which we need to consider when we read an economic evaluation around discounting, and typically you will find some information around discounting in the method section. For example, could be that cost and QALYs, for example, were discounted at 3.5% per annum, or when the time horizon was quite short, then no discounting was applied. So, you know, if you have only 1 year of analysis, it doesn't really make a lot of sense to do any discounting. I'm going to talk about the homework, and then I'll take any questions after the session. The homework is again about outcome data and discounting, and we are going to ask you to complete this task by the next session, which is on Monday, 14th of July. As usual, you can find the homework document on Teams, session 4 outcomes. You open the folder and you will see a document with your name. And again, you will have another table to fill in, this time about outcome data. So you'll have some information about the type of outcome data you're going to extract from the paper, the question, and some definition about the specific element you will need to focus on. And then the last column is all about trying to find the information and paste that information into that column. So this is it for today's session. We are going to see you next time at session 5 on Monday, the 14th of July. We are going to take any questions now, but I'll stop the recording first, and I'll see you next time. Thank you.